Okay, so officially, hello and welcome to everyone. Welcome to Understanding Your Patient Rights, a live panel discussion with an emphasis on myalgic encephalomyelitis, also called chronic fatigue syndrome or ME/CFS. And this panel is brought to you by the Human Health Project. I am Taryn May. I'm HHP's online event coordinator, and I am your Zoom host for today. So you're welcome to message me privately through the chat feature if you run into any issues. And to keep things simple, I've disabled our attendees' microphones and videos until the Q&A session. Please feel free to add your questions to the chat during the presentation. I'll be collecting those questions as well. If you do add a question to the chat or you plan to ask a question in the Q&A, please do let us know which panelist you'd like to direct that question to. So now I'd like to introduce our amazing panel, and thank you to our panelists so much for being here today. From ME Action, we have Ms. Wilhelmina Jenkins, an ME/CFS patient advocate for over 30 years, including outreach work with the National Institutes of Health and the Centers for Disease Control and Prevention. Also from ME Action is Terry Wilder, a social worker and ME/CFS activist with over 30 years of healthcare advocacy and activism experience. Terry is the co-leader of ME Action New York and represented the organization on the Federal Chronic Fatigue Syndrome Advisory Committee. We also have Emily Taylor, Director of Advocacy and Community Relations at Solve ME. And Emily is also a caregiver with over 15 years of policy and advocacy experience. And last but not least, we have Orla Ni Hori, Secretary of the Irish, thank you, of the Irish ME/CFS Association and patient advocate for over 15 years. And then moderating the panel is the founder of HHP, Dr. Phil Harrington. So Phil, I will hand it over to you until the Q&A.
Great stuff. Thank you so much, Taryn, and for putting the panel together. And thank you so much to our speakers and to everybody for attending. I am going to begin with asking Terry to lead off as the first speaker. So over to you, Terry.
Great, thanks. I'm going to share my screen, so just give me a second. Great. If somebody can give me a thumbs up and let me know if you can see the screen. Fantastic.
Yep, you can see it.
Great. So, like was said earlier, I'm Terry Wilder. I'm the ME Action New York State co-leader, and I'm going to talk a little bit about rights kind of from the helicopter view, kind of looking at it from a more kind of philosophical way of looking at rights and how we engage in activism. I'm really going to be kind of thinking about self-empowerment and disability justice, which we'll dive into kind of what that means in just a minute. So I want to start out by telling a little bit about my story. So I think I was born an activist. So I was born in October. It's the sign of Libra if you're into horoscopes, and that sign is about justice. And so I was born in that month, and I think I might have come out of my mother ready to kind of fight for people's rights. I should also mention that my great-grandmother ran for US Congress, which was really kind of back in the day, not something that a lot of women did. Of course, she didn't win because women never won any kind of seat back then. So I kind of look at it as I was born under the sign. I had this genetic predisposition to being an activist. And then later in my life, I ended up going to the University of Georgia and getting a bachelor's and a master's in social work, which social workers are known for, you know, advocating for change and getting involved in social justice issues. In March of 2016, I was diagnosed with myalgic encephalomyelitis and, you know, had a lot of the symptomology that I think we're all familiar with, the pain, the exhaustion, the light intolerance, the sound intolerance, the brain fog, etc. And like many of our stories, I probably had this since the 1990s, probably the 80s, and there were certainly signs and symptoms as a child. I was lucky that I was living in New York City at the time, had met Jen Brea, the co-founder of ME Action, and she referred me to a physician, Dr. Susan Levine, who diagnosed me. And of course, at the time said, "I can't even believe you're working," which at that time I could barely get to work. But one of the things that I couldn't believe was, how did I get diagnosed with a disease that doesn't have a biomarker, doesn't have an approved treatment, has all this stigma, nobody cares about it? It reminded me a lot of my work in HIV, because that's a very similar story to what people with HIV went through in the early years of the epidemic. There was no federal response. There was no FDA approved drug. There was no, warm embrace of helping folks with this disease. And so what's interesting about my story is, because I was a social worker, I was introduced to the HIV community and the LGBTQ community in the late 80s because of my work as a social worker. So I really consider myself being raised by HIV and LGBTQ activists. And I think it's important for you to know that, because it gives you the framework of which I kind of perceive rights and justice. So for folks who are unfamiliar, HIV and LGBT activists, are a very organized community. They have been very successful in getting things that they need for their community. Certainly, AIDS activists were able to get FDA-approved drugs, get a seat at the table at different government institutions to make change happen. In the United States, they have the Right White Care Act, which is millions and millions of dollars to help fund medical care and social services. But they were very in your face, and they very much spoke truth to power. They called out the president of the United States. They would, have not so nice conversations with folks in federal government, because they were desperate to make change, because everybody in their community was dying. And one of the most famous groups is the AIDS Coalition to Unleash Power. And I encourage you to read about them, watch the documentary How to Survive a Plague, so you can see some of the strategies that they use to make change. So I bring this up because there's a very important document that was created in 1983 called the Denver Principles. It's very easy to Google. You just type in the Denver Principles 1983. And the reason why I want to bring this up is because when I think about living with ME, I really use a lot of my philosophy and my activism from the Denver Principles. And when I read this document, I feel like I could substitute the acronym AIDS for ME. So let me give you an example. The very first section of the Denver Principles is very powerful to me. And this is, like I said, a document that was created in 1983. It was created by people with AIDS during a conference that was being held in Denver. Imagine what was happening in 1983 if you were a person with HIV. You didn't have a lot of information. We didn't really know if you were going to live or die. There was a lot of stigma. There was a lot of shame around this disease. And so one of the very powerful pieces of this document is the beginning. We condemn attempts to label us as victims, a term which implies defeat. And we are only occasionally patients, a term which implies passivity, helplessness, and dependence upon the care of others. We are people with AIDS. They very much wanted to be referred to as people with AIDS, not to be called a patient or a victim or, an AIDS patient. They very much wanted their humanity to be first and when they were referred to. Some of the other real pieces in this principle that I think about constantly are the rights to have quality medical treatment and quality social service provision without discrimination of any form, including sexual orientation, gender, diagnosis, economic status, or race, and to full explanations of all medical procedures and risks, to choose or refuse their treatment modalities, to refuse to participate in research without jeopardizing their treatment and to make informed decisions about their lives. Another principle that's very, very dear to me that I fight for all the time is for us to be involved at every level of decision making, and specifically serve on the board of directors of provider organizations, and to be included in all AIDS forums with equal credibility and other participants to share their own experience and knowledge. I very much was taught from the HIV and LGBT community that the person with the disease is the expert. We live with this every single day. I only see my medical provider 20 minutes every couple of months. While I partner with them and collaborate with them, I am the expert in this experience, and I should be at the table. You know, organizations should be hiring people who have this disease so that we can be able to direct and, you know, navigate all of the issues that affect our lives. I also want to share another inspirational group that put together something that is very important to me. But I first want to quickly just talk about, you know, when I say activism, what do I really mean? And what I'm talking about is something that is fundamentally about power. It is action people take individually and collectively to challenge power imbalances and create positive change. So when we talk about power, we're talking about the ability to shape the structures and systems that impact people's life experiences, and specifically their ability to enjoy the civil liberties and civil rights promised to us all. So activism is a change process and a way to exercise power. So when we think about like getting our rights, it's about a change process, and that we have to be able to speak truth to power to make that happen. So over the last couple of years, I've really been thinking about like, what's the difference between disability rights and disability justice? Well, disability rights is really kind of a framework that came out of the 70s. It was mainly white people who kind of were part of this disability rights movement in the United States. They were known for helping to get the Rehab Act of 1973 passed. But now I want us to think about disability justice in a more nuanced way of thinking about our movement of fighting for rights. So disability justice is a framework that examines disability and ableism as it relates to other forms of oppression and identity. So I'm talking about race, class, gender, sexuality, citizenship, incarceration, the size of our bodies. And this is different from disability rights. So disability justice really uses an intersectional lens to bring a more nuanced and active approach to the movement. And it really challenges our assumptions about ability, embraces all kinds of bodies. So the disability justice frameworks really looks beyond the commonality of disability to incorporate others' identities. And when I talk about anti-oppression, what we're talking about is, you know, anti-oppression actively works to acknowledge and shift power towards inclusiveness, accessibility, equity, and social justice. And I think anti-oppression is very difficult to recognize, particularly that we all oppress others. And we need to recognize that we do and work to not do that and think about the work that we do in a very intersectional approach, and how we're thinking about equality when we really need to be thinking about equity. So again, the 10 principles of disability justice were created by Sins Invalid, which is a majority queer organization combined of Black and Brown people. And I encourage you to really read this, but I'm just going to highlight a couple of pieces. So leadership of the most impacted is a disability justice principle. And there's a quote that says, "We are led by those who most know these systems." So your leadership should be the person with the disability. We should be committed to cross-disability solidarity. So we need to honor the insights and participation of all of our community members, knowing that isolation undermines collective liberation. And then finally, when we talk about collective liberation, so we're not if one person is not free, if one person does not get justice, then nobody has justice or freedom. So we really need to come from a place of collective liberation, that no body or mind can be left behind. And only mobbing together can we accomplish the revolution we require. So, I think about this when I, go to my medical appointments. When a cardiologist that I went to several years ago, and I asked, what do you know about ME? And they said, oh, I don't know much about it. And I told them, and then they ended the conversation by saying, well, you need to exercise. And, some medical providers don't believe ME is real. So as I was thinking about those messages that they were giving me, they're telling me that they don't believe me, even though they framed it as some medical providers don't believe in me. She wasn't acknowledging that I was the expert in the room, because I know that exercise can harm me. And, what I did was I took the tools that I learned from AIDS activists and LGBT activists, and I called the next day and I complained about the way that I was treated. She became very condescending to me, very snippy to me, because she didn't believe that I was sick when I came to her. I also use these philosophies in what's called outside strategy. Many of you may know Perfink is a medical provider in another country that doesn't believe our disease is real. And he was invited to the United States, to Columbia University. And we had a protest to let him know, we don't want you here. You are harming people, and we're going to make it very uncomfortable for you to be here. So we had a protest outside of Columbia University to make sure that the people going to this conference knew that this person had done harm to people with ME around the world. So I'll just close by saying that, there's lots of opportunities for us to engage in activism. And I just wanted to provide a framework today of things that have been really helpful to me to think about my role as an activist, and my reflection on how I navigate the world to get things that I need and to fight for the rights of other people in my community. I want to make sure, for those folks who are on the webinar, the resources in the United States, if you ever have issues with anything that's going on with you, don't forget that your elected officials, your senators and Congress people, as I call them, Congress critters, they have caseworkers that are available to kind of help people navigate things. It's a soundboard for you to complain if something's not going in your favor, if you feel like you're being discriminated against. Also, at the federal level, we have an Office for Civil Rights that you can file complaints about if you feel like your civil rights are being violated. And I'm just going to close here by sharing a little piece from a speech by an AIDS activist, Vito Russo, from 1988. And I hope it'll give you something to think about when you're thinking about fighting for your rights and the rights of others. In the speech, he said, if I'm dying from anything, I'm dying from the fact that not enough rich, white, heterosexual men have gotten AIDS for anybody to give a shit. Living with AIDS in this country is like living in the Twilight Zone. In a lot of ways, AIDS activists are like those doctors out there. They're so busy putting out fires and taking care of people on respirators that they don't have the time to take care of all the sick people. We're so busy putting out fires right now that we don't have the time to talk to each other and strategize and plan for the next wave and the next day and the next month and the next week and the next year. And we're going to have to find the time to do that in the next few months. And we have to commit ourselves to doing that. And then after we force the shit out of this disease, we're all going to be alive to force the shit out of the system so that this never happens again. So if you think about fighting for the rights of yourself and the rights of everyone else in your world, we're really fighting to make sure that this never happens again. So thanks for letting me share my thoughts about rights and how to speak truth to power. Remember that knowledge is power and that silence equals death. And I encourage you to follow me on Twitter. And if you have questions after the program, please email me at terry@meaction.net. Thank you.
Thank you so much, Terry. That was amazing, amazingly inspirational and informational. Thank you so much. Lots and lots to take away there. I'm going to be having a listen back to your talk later and look at those links and so on. Thank you so much. Our next speaker, who is in Ireland, in Galway in Ireland, is Orla. And I'm going to hand over to Orla, who's going to share her experience with the condition and also to do with patient rights. Thank you, Orla.
Okay, thanks very much, Phil. So I'm going to talk a little bit about myself first. So my ME started in 1998, a few weeks after an infection. So my main symptoms in the early stages were nausea, sleep problems, continuous headache, dizziness, concentration and memory problems. And after a few weeks, I started experiencing muscle pain. And I also started to have problems walking after a while, where I would fall over every few steps. So I had very good concentration before the ME started, but suddenly I had trouble following conversations and remembering simple words or the meaning of them. And I would have to ask people to keep repeating things, as I wasn't able to follow or remember what they were saying. Because of these neurocognitive problems, having help from an advocacy service can be very useful, and I'll talk about them in a little bit. So another symptom I was getting was post-exertional malaise, but I didn't know what that was at the time. And in the first few weeks, I would do an activity one day, such as a short, gentle walk on a good day, and would wake up feeling very sick the next day. Now, I was used to, before this, I could walk a few hours a day, and this, I'm talking about maybe going out doing 10 to 15-minute walk and feeling very sick afterwards. But because the activities were so minor by comparison to what I was used to, and because there was a delayed reaction between doing the activity and feeling worse, I didn't see the pattern at first. And this is where a diagnosis can come in useful, as you can learn about this aspect of the illness and how to manage it better. So my story is a bit unusual, as I got diagnosed relatively quickly, within about 2 months. But I did switch from my original doctor to see another doctor a friend of mine suggested, as I felt the one I was seeing was not good at listening. And in general, I had never found it that good. Unfortunately, it can be much more difficult now to switch doctors in Ireland, especially if you're a medical card patient. So that's for people on very low income, due to a shortage of GPs, especially in rural areas, unfortunately. And in a way, by the time I got diagnosed, it was actually a relief to get diagnosed, even though by comparison to other people, I wasn't waiting that long. At that point, though, I thought I had a good chance of recovering within the year, which of course didn't happen, because this was back in 1998. Luckily, I got good advice at the beginning from this new doctor I was seeing. So he suggested pacing and gave me something for sleep. And unfortunately, even though I improved an awful lot in the first year, I've had relapses since, and I've never recovered, unfortunately. So other than rest and pacing and medications to help with sleep, mobility aids are the other main thing which I found useful, and the main one being the mobility scooter. So I borrowed a wheelchair. I was on holidays in the Isle of Man in Britain in 2004, and they had a scheme where the Red Cross had a scheme where you could borrow a wheelchair off them. And it made such a difference to what I was able to do that when I went home, I bought a mobility scooter. And since then, I've bought a much lighter weight one that I can fold up and put in the car. And it's made a dramatic difference to my quality of life. Unfortunately, the health service in my area doesn't cover the cost of mobility scooters or light fold-up electric wheelchairs either, which is very poor, I think. So I'm just going to talk a little bit now about the rights. So the most useful right for me was finding out that I could get my personal files from public bodies under the Freedom of Information Act. So I'm going to give an example, a practical example of where this can be used. So I was turned down for a social welfare payment after a medical assessment, and I went to a local centre which advises people on welfare and employment rights, and they suggested I applied to the Department of Social Welfare for my file under the Freedom of Information Act. I realised when I saw the file that there were things which the examining doctor had not understood, and that it was not enough just to answer the questions as he asked them, as the questions were more geared towards other conditions, and it meant that some of my main symptoms and problems were not mentioned in the file. So the centre also advised me to ask for a second medical, which I got, and I passed the second time around, no problem. And I knew this time to proactively volunteer information and not just answer the questions I was asked. It's like you have to prove you're innocent rather than they have to prove that you're guilty. So there are citizens information centres around the country which can also help advise on appeals like this. And they have a good website with information on rights and entitlements. And I'm just going to citizensinformation.ie is the name of it. I'm just going to share screen now. And so that's the web address there for anybody in Ireland. So I'm going to talk a bit now about accessing your own patient records. So my doctor's surgery is very good at information sharing, but even with more reluctant doctors, patients do have rights when it comes to accessing their personal medical records. So public patients here can apply for their file under the Freedom of Information Act, and public patients include those seeing a doctor under the medical card scheme, the doctor visit card scheme, or patients of a publicly funded hospital. So both public and private patients can also use data protection laws to access records. So some of these laws apply across the EU. So people will probably have heard of GDPR, which stands for General Data Protection Regulation. And under these laws, you're entitled to find out if there is information about you held on record, to access those records, and to have them corrected if they're inaccurate. And GDPR laws apply to both public and private healthcare providers. So that's everybody. And the citizens' information has more information on rights on accessing your personal information, which is held on file about you. And there's a few agencies here which can help in terms of getting your rights respected. And one of these is the Patient Advocacy Service. So they help people make a complaint about care they have received in a public hospital or HSE-run care home. I can't recall anybody I know with ME who's used this service, so I don't know how good it is or how serious a problem would have to be for it to be taken seriously, but they could still be worth contacting to talk to anyway if you had a problem. So patientadvocacyservice.ie is the web address. And another service is the National Advocacy Service. And they said this about themselves, that they're there to assist and support individuals, in particular those with disabilities, in identifying and understanding their needs and options and in accessing their entitlements to social services. So I know people with ME here who've used this service and found it very good, but the waiting list, unfortunately, can be months long at times, and their web address is advocacy.ie. So another option is there's now social workers for adults with physical disabilities and illnesses, and they can be very helpful at getting information or even helping to advocate on your behalf. I had a very good social worker myself who helped me out, but I do know somebody else with ME who was in a different area and had a different social worker, and she didn't find them that good. So it probably depends a bit on who you see. So for students as well, ahead.ie is worth contacting if you're going on to third level or further education or training after school. And I've actually seen them as one of the few agencies here that mention ME proactively in pieces they've written in the press and that. So they seem to have an above average level of awareness of the condition. So they look to be quite good to contact if you're a student or going on to third level education or post-primary education. So as Terry Wilder mentioned, actually something that I'm going to mention now, if you're stuck, I would suggest contacting your local politicians. I actually found this very useful myself in relation to housing issues I was having, where it was coming up against a bit of a bureaucratic brick wall, and they actually helped me navigate that. And I also discovered from one of them that there had been a change in local housing regulations for social housing, and it meant that I could access social housing more quickly. So I did actually find that very useful myself, and I know other people access this route, and sometimes it just moves things along. If I find sometimes with bureaucracy, if they know you have an advocate, you sometimes just get treated better and things get dealt with more quickly. So just one last thing in relation to treatments. So informed consent is meant to happen in relation to treatments, but sometimes patients are not being informed of the risks of certain treatments, such as graded exercise therapy. And patients only find out there's an issue if they get worse and find out other patients had similar problems. And Tom Kindlin of our group, the Irish ME CFS Association, has suggested that there be a reporting system put in place for reporting side effects and harms from prescribed non-drug treatments, similar to the current system for reporting adverse drug reactions. So I just thought I'd throw that in there as something to think about to try to campaign for in the future. Okay, thanks very much. And just apologies, I was sort of reading out there, but I have a bad memory. So I thought I was better to stick to the script, otherwise I might go all over the place. Okay, thanks very much.
That's great. Thank you so much, Orla. Could you stop screen sharing there?
Oh yeah, sorry.
No problem at all. So thank you so much for that talk. That was so informative to hear all that information that you shared and very inspirational. Thank you so much, Orla.
Thanks.
So our next speaker is Wilhelmina. And Wilhelmina is in Georgia in the United States. And I'm going to hand over to you, Wilhelmina. Thank you so much for sharing your knowledge and experience.
Thank you so much. It's good to be here. And my name is Wilhelmina Jenkins. I have lived with CFS for 38 years, more than 38 years. I became ill in February of 1983 while I was working on my PhD in physics. I was teaching classes. I was doing research at a government laboratory near my hometown of Washington, D.C. And abruptly, all the dreams that I had of a life in science surrounded by eager students were shattered. It was all over. My world was circumcised by pain, exhaustion, cognitive disruption, which was by far my most painful and heartbreaking symptom, and a host of other symptoms. Terry showed you the word map of all of the multiple symptoms that come on with this illness, and I had a good share of them. Unfortunately, no one was able to tell me what was wrong with me. There was no real good source of information about this disease at that time. They were not unkind, but they were completely lacking in knowledge. My family moved from DC to Atlanta, Georgia in 1987, and here I was able to get a diagnosis. There were doctors here who were connected with the effort that the CDC was doing at the time, and questionable as that was, but I was able to find a diagnosis. And most people who know me know that stretching out diagnostic information to all sectors of this country and around the world is one of my passions, because without a diagnosis, you can be very, very lost. I felt that I was the only person in the world that this had ever happened to. I received the diagnosis. There is no treatment. I was mostly housebound at that point and sometimes bedbound. But as horrible as all of this was, it was not the worst thing that happened. Far more heartbreaking for me was the day that my wonderful, bright, energetic teenage daughter came home from high school and collapsed on my couch with the same disease that had so drastically changed my life 8 years earlier. Initially, I was so stunned that I couldn't believe it. I knew that there was a tendency to have this run in families, but I couldn't believe that it happened to my family. And as we talk about patient rights today, I want to look at the rights that my daughter had when she became ill. Those were the ones that were most important to me. And some of those are relevant to her age, but many of those are true for all of us. Some of them are just basic human rights, and some of them are backed up by law and need to be backed up by law. And first basic human right for all of us is the right to be believed. I'm going to say that again because it's so important. We have the right to be believed, to be heard and seen and understood. ME/CFS is a highly stigmatized illness. Here in the US, as well as in countries around the world, this disease has been trivialized and dismissed as psychological. We were mischaracterized as having yuppie flu or burnout, or simply being unwilling to push ourselves to regain our health. Comedians around the world have made jokes about us. Young people have been accused of having school phobia, and some young people have even been removed from their homes, supposedly for their own good. Even the name given to this disease here in the 1980s, chronic fatigue syndrome, added to the stigma. Every last one of us has had someone come up to us and say, yeah, I'm tired too. If there was any advantage to my having become ill first, it was that I knew that every word that my daughter said about how she felt, the pain, the exhaustion, the nausea, the brain fog, was the absolute truth. She didn't have to fight me. She didn't have to convince me. I knew that she was telling me the truth. And at that point, we needed to find her a doctor. And that's another right. Everyone has the basic human right to competent and compassionate health care. But sometimes finding the right healthcare professional can be a challenge. The first doctor that I took my daughter to see was a disaster, a complete disaster. In her office, my daughter's blood pressure was so low that 3 staff members in the office could not get a measurement at all. The poor child was barely standing up. Finally, the doctor herself came in, and after some effort announced a reading of 60/40, which is a disturbingly low reading. I'm going to point out that my daughter and I, who laugh a lot together, used to sit on the couch when neither one of us could move, and we would watch medical shows on TV. And we constantly heard blood pressure, 60/40. We're losing them. We're losing them. And this doctor was not moved at all. Her reaction was to recommend that my daughter see a psychiatrist. I was furious. We left immediately, and I called our insurance company demanding that they find a competent doctor for my sick child, no matter how far we might have to travel. They asked me to find one more doctor whose practice was right in Atlanta. I was skeptical, but I was willing to give it a try. I went in carrying a huge stack of the latest information about our disease. And when this doctor entered the examination room, he introduced himself, recognized the information that I had brought because he had the same information and was knowledgeable about it, and said what I think every doctor should say. He said that he understood what a terrible disease we had, and he pledged to do whatever he could to make us feel better. I was there primarily for my daughter, but he said, you too. We had found a partner. We still see him 30 years later. He was honest. He made no promises about outcomes. Honesty is essential. We have the right to be told the truth. He's respectful of my daughter and me. We were never stereotyped in the way that African Americans often are in this country as drug seekers or malingerers. Many people, many African Americans, when they go to a new doctor or to an emergency room, immediately are given drug tests that are not given to the rest of the population. My doctor never had any of those problems. He's also always been very careful about researching treatment options. He's open to treatments that seem both safe and promising. He discusses the options with us and respects our decisions. We were very lucky to find him. I know that it's difficult in many, many places to find a doctor who is that understanding and open and respectful. And I know sometimes in many countries it's difficult to change doctors, but every patient should have the right to this kind of knowledgeable and respectful care. And I think we all need to work to make sure that happens. Once we had a medical partner, we were ready for our next challenge, my daughter's education. And here's another right. Every young person has the right to an education and is entitled to whatever accommodations they need to best obtain that education. That's going to vary from country to country. If you Google, and Google is always our friend, if you're in your own country, Google patient rights and education, you'll find out what you're entitled to in your own country. We looked carefully to find out what we were entitled to. The range of disability in young people, just as it is in adults, is very wide. Those who are the most severely ill may have to put their education on pause. My daughter was not in that category. One reason I believe is because we were able to catch it very early and had a good doctor backing us up. But that meant that she had options. One option she could have exercised was homeschooling. And this is absolutely the best solution for many young people with ME/CFS. It means that they can put their energy into what matters most, learning. This is a time when I had to remind myself that my daughter had the right to make the final decision about how she wanted to pursue her own education. And above all, she wanted to continue in-person school. This was a bit frightening for me, but it was her right. I had to allow her to make that decision. And we talked at length about the sacrifices she'd have to make in order to continue in-person schooling. And then we researched what accommodations she was able to request. For example, there was no way that she could get to school early in the morning. She was entitled to a reduced schedule. That was her right. We eliminated early classes. Sometimes even with her altered schedule, she would arrive at school too sick to get out of the car. We'd go back home, medicate, hydrate, rest, and she would want to try again. She used the summers to make up the classes that she had to eliminate from her schedule. There were many accommodations that helped her. And there were a lot of teachers there who were very understanding. Her counselor was understanding. However, there were a few who were not. But her doctor's office was very close to her school, which was wonderful because at lunch hours, sometimes she would go get treatments, come right back to school. She had no social life, no hanging out at the mall, no parties. Everything else was eliminated. But she was able to complete her graduation. And at graduation, as the other parents were cheering, I burst into tears, remembering all of her struggles to get her to that day. There are a lot of rights we could discuss. We're out of time, but the right of privacy is one. The right to speak out, as Terry mentioned, is one for sure. But what I hope for each person, young and old, living with ME/CFS is the right of autonomy, the right to continue to be who you are and to decide for yourself how to conduct this very, very difficult life. There are lots of us who see you, who know your struggle, and who honor the person that you still are.
Thank you so much, Wilhelmina. Really appreciate that wonderful talk of yours. Very, very inspirational, informational. Thank you so much.
Thank you.
And now we're going to hand over to Emily, who's in Los Angeles, who's our last speaker. And then we're going to have a Q&A. We have a little bit of extra time after the 10 minutes for the Q&A. Thanks so much, Emily. And thank you again, Wilhelmina.
Thank you so much, and again, thank you for those wonderful comments from the previous speakers, truly developing, I think, a comprehensive picture that patient rights are a spectrum. There's no definitive yes or no. You heard from Orla how there's really robust resources that are accessible in Ireland, and sometimes you heard from Wilhelmina, sometimes in the United States, those resources are not as accessible, or you need different bridges or navigation tools to get to them. And as you heard from Terry, it's systemic. These are issues that touch all parts of our lives and all parts of our government and all parts of our society. So today, while this is a huge topic, I'm going to zero in on the role of family and caregivers, which is where I can bring both my professional and predominantly my personal experience. So thank you again for that kind introduction, Phil. My name is Emily Taylor. I'm the Director of Advocacy and Community Relations for Solve ME. And like many of us in the nonprofit sector, I have two hats. I am also the senior staff for the Long COVID Alliance. So this is a little bit about me on this slide, about my professional background, but really today I'm speaking about my personal experiences as a caregiver for my mother, who has battled chronic illness since 1999 and was diagnosed with ME/CFS in 2012, despite years of struggling and flare-ups and pushes and crashes that so many in the ME/CFS world are so familiar with. Again, like many who have had and struggled with this difficult illness, my mother's illness started with a virus. She had visited me when I was living and working in Washington, D.C., and on the flight back, she spiked a fever, went home, thought it was just the flu, tested, tried some antibiotics that were not effective at all, which is when we came to the conclusion with her doctors that it was viral in nature. She sort of came out of it after about a month and a half and then fell ill once again. And 4 years later, we received the diagnosis of ME/CFS. I share my mother's story because she was fully bedbound at one point in time and now has about 50% of her life back. And that was a 10-year journey. So I really do want to focus on a message of hope and collaboration, that when you come together as a team and as a family, there are options and improvements out there. And I heard a lot of folks talk about this disease, ME/CFS, as it's not a death sentence, it's a life sentence, which is a painful way to look at it, because it is a chronic illness that for many people does last the entirety of your lifetime. But that does not mean, as Wilhelmina says, that you lose your life. You have a right to a life, even with your illness. And one of the roles of caregivers is to help be that bridge to provide that to you. So caregivers, I see, has two different but very important critical roles, especially family caregivers, who I think bear this burden with an extra weight. So the first is obviously a bridge. I love the idea of a bridge, bringing a connection between two items that are otherwise divided, two sides of a chasm, two edges of an island, to the mainland. Like, bridges are so critical in our world. And I love this analogy of using the caregiver as a bridge. Hold your loved one's hand and then reach out for the rest of the resources or what they need. All the while recognizing and preserving the autonomy and self-interest of your loved one. You don't want to ever overbear them. You don't ever want to push them. Again, you're the bridge. You're not shoving them into the water to get to where you think they need to go. It's their decision where they need to go. And it's your job to be the bridge to help get them there. So obviously this bridge role applies to resources. You'll see there a link, hyperlink there that goes to the SolveME caregiver and patient resources page, which is a great starting point if you're in your early stages of trying to learn your way around this unique illness. Obviously, the caregiver is a connection to patient rights and representation. As Wilhelmina and Orla and Terry described, there's a lot of nuances to patient rights that, you know, your average person, if you haven't been forced into this world by an illness, you're not really aware of. Oh, wow, I didn't think about the doctor's office or, you know, the disability community or even the educational setting as areas in which these illnesses and these symptoms can cause harm. So that's a real important role of the caregiver is identifying and bringing in patient rights and representation into the conversation. Obviously, the caregiver is a critical part of the medical team. And my comments today really focus on the last three bullets here: your medical team, your advocacy work, which is of course my background and my love, and of course being a supportive family and loved ones is so critical to both mental and physical well-being for the person you're caring for. So this is not a comprehensive list by any means, but I wanted to dig into a little bit more detail what a bridge looks like in these specific areas. In a medical team, the caregiver role really is around records, research, and journaling, which again, supportive role. Maintaining records is so critical and key. Insurance and billing, which is a maze even for the healthy person. So definitely it's understandable that your person in your life who is experiencing complex symptoms or is experiencing ME/CFS will need support in navigating that, because I'm healthy and my head still spins when I try to look at a medical bill. Asserting the patient's rights in the medical environment. It's really, as both Wilhelmina and Terry and Orla described, being alone in that environment where you're a patient, you're passive, you know, the doctor is the expert, they're sort of dominating the conversation. It can be hard to find the space within that to assert your patient rights, to assert your needs. And caregivers can be so helpful in creating that space. Hi, I'm so sorry to interrupt, but I know my mother really wanted to talk about this subject. Is there any way we can save some time for that? Simple, easy, and of course, I can be the assertive person in that regard. And of course, identifying potential trials and treatments. I also call this research, especially for folks who are experiencing brain fog. Digging into the drama that is PubMed or a medical journal can be really overwhelming. So again, this is where healthy caregivers can really be valuable, doing that research, like summarizing things in a very simple way, and helping break that down for your loved one who's trying to understand this experience they're going through. And of course, again, they are the expert, and I have to emphasize this enough. I cannot emphasize this enough, that, you know, the patient is always the expert on their experience. So lastly, I'll just share a little bit about the advocacy work. Terry did a great job talking about activism, so I'm not going to repeat all the great insights that she shared. But I like to use the term advocacy. Advocacy is generally an inside game, whereas Terry showed you the great the great pictures of the Terry Fink protest, which was fabulous, and that activism was so highly effective, versus perhaps an advocate in that role might have attended the conference, spoken to Peter directly, attended the panel, raised your hand and asked questions in that inside context. So that's a kind of a good illustration of how I see activism and advocacy being two sides of the same coin, working together for that common systems change. So advocacy, again, is that inside baseball kind of terminology. You can be an advocate in the government and public policy space, which is kind of what I call quote unquote big advocacy or society level advocacy, inclusion, representation. This can be everything from, you know, showing a person in a wheelchair on a big TV show to having Dr. House talk about ME/CFS as a potential differential diagnosis. There's so many different ways that societal advocacy can take part, and caregivers can be such a great bridge to societal advocacy, because of course your loved one is sick, right? They're really struggling. They have to focus on their health first, but there's other level things of taking that health journey and telling that story, sharing the policy outcomes or sharing the harms that were caused. That's the society level advocacy that caregivers can really be a shining star in, because they can preserve the health of their loved one and yet still get their story out there to change the world. Now, advocacy can also be used in terms of individuals, which when I always ask my folks I work with, are we talking big advocacy or little advocacy? And little advocacy does not mean that individual advocacy is not as important. It's just a sense of scale, because navigating a disability process is just as complex as navigating Congress. I can tell you that firsthand. Workplace education and accessibility supports, just as hard of a fight as getting a bill passed. Again, I speak from experience. Convincing family or friends that this person is really sick and needs their support, harder than convincing a staff member to pass a bill, definitely. And so I think all of these individual advocacy and societal advocacy is actually sort of the same skill set, just where you choose to apply it. So stepping back also, so this is everything that you can do as a bridge, being a caregiver for the person you love. But depending on the illness and capabilities of the person you love, sometimes you are the bridge and sometimes you are the car, because sometimes the person you love doesn't just need a connection, they need a hand. They need someone who will physically do that thing for them or access that item for them. Or maybe they're too sick to even attend if it's far away or requires travel, and you have to go and be the representation of that person. So I love the analogy of the bridge, because I think it's beautiful bringing these things together. But sometimes you do have to be the gasoline, driver, navigator, and car that gets the needs across the bridge, because it's not just there to get the items and identify where they are, but you also have to get to them. So a little bit about what being a car as a caregiver can look like. First of all, in the medical team, I always start there, because that's, I think, the central experience that that brings a lot of this commonality together. Home management of medication and supplements. That is typically something most people expect to do for themselves. But again, for those with ME/CFS who have seen the dozens, if not hundreds of pills that will flow through your fingers every month, keeping which dosage, what time of day, taken with food, taken without food. Oh my goodness. So managing medication and supplements, I think, is a really helpful first step that caregivers can do to just take a little bit of pressure and give those spoons back to the person they loved. Providing home care treatments. Some caregivers never thought they would be the one changing a feeding tube or a PICC line, or providing in-home medical treatments through injections, or even some other kinds of medication delivery systems. These are sometimes things you have to do. You have to actually provide the care to the person who is maybe unable to provide it for themselves. And then most importantly, and this is one that I really would like in all caregivers and carers to take a moment to think about, is medical decision making. If the situation ever comes up that your loved one or your care charge is unable to communicate or make their own decisions for themselves, you have to be informed to be able to express their needs when they are unable to do so. And that, I think, is one of the most critical car components of being a caregiver, is knowing that this disease is variable. There are some days that my mother can do everything that I can do and more, and I need to step back and let her take charge of her own life. And then there are the other days, the bad days, when taking a shower is about the limit of her capacity. And on those days, I need to step in and be her voice. And so I think ME/CFS is a unique challenge as a caregiver, because most diseases have a pretty steady quality of life, or a pretty known trajectory, right? We know what's going to happen with most types of cancers. We know what's going to happen with most types of glaucoma, most types of autoimmune diseases. We have a clear trajectory, or clear what we call natural history of what's going to happen with that disease. With diseases like ME/CFS, we don't have that knowledge base. And as Wilhelmina and Orla and Terry can tell you, there are ups and downs, good days and bads. You never know what tomorrow is going to look like, and whether your body's going to be with you or against you that day. So, so recognizing that variability as a caregiver is, I think, the extra critical step for an ME/CFS caregiver, being able to both step in and step out, be the car or the bridge, whenever the person needs it, and identifies those needs to you. Quality of life is, I think, a critical component of being a quality caregiver. When you're a bridge, the person is pretty self-sufficient and is managing their own life. So you can do those extracurriculars, if you will, things like insurance, things like medical research, all those extra items. So, social research or social advocacy, going out to Congress, you have the space and time to do that, if your loved one is meeting the basic needs of quality of life. If they aren't, again, that's where you need to be the car and step in, ensuring that your loved one has the basic security, physical security, housing security, food security, economic security. Check those 4 boxes off before you worry about anything else. Monitoring mental health. This is another one that I've talked about.
Emily, could I ask you to wrap up there now? Yeah, we're up to 15 minutes there from you, and we just need a few minutes left for the Q&A.
Right, understood. I'll move along. I'm almost done. Obviously monitoring mental health is critical because mental health is a component of physical health and your overall well-being. And additionally, mental health is something that I think a caregiver gets a special look at behind the scenes. A doctor, as Terry describes, who sees you every few months for 20 minutes is not going to see the whether you're really hanging in there. And so again, mental health monitoring is really important for quality of life overall. Last but not at all least is the family team, being a social and emotional source of support, and of course taking care of the household tasks when that person is able to do so. Basic things like running errands, paying bills, remember birthdays, all the things that you do in your daily life that you don't even think about for someone who has to manage energy levels at a very careful, meticulous level of detail. Those little supports can be a life changer. So this is a quick look at a caregiver bill of rights. Some of these are very essential, but I can summarize this in a very quick way by saying it is the caregiver's right to take care of yourself. You have to put on your own mask before you can help others put on their mask, as they say on every airplane that you take off on. And there's a reason for that, because if you are collapsing, you cannot be a source of support for the person you're trying to help. So again, take care of yourself, serve your own rights and well-being first, and always prioritize your own individuality and needs. Last but not least, I will just quickly touch base on what I've summarized here as kind of the quick, easy way that caregivers can be helpful in regards to patient rights for their loved ones. Listen. And remember, that's also important. Express needs and desires, especially if you're working with people who have a severe brain fog, or in the case of my mother, some speech aphasia. Listen to the meaning of what your loved one is trying to say instead of the actual content of what they're trying to say. They might misspeak, and you shouldn't let some perceived slight or perceived quickness of their words reflect what you know they're trying to say. Record. Always get it in writing. Keep records and manage them with care. If your patient is not present and you're trying to represent them, make sure you record it. And learn about HIPAA, learn to navigate HIPAA. It is your friend, it is your enemy, but it is however you use it, which turns it into one of those two things. So learn about HIPAA to learn to navigate HIPAA, and as a caregiver, it can be your best friend. Represent your loved one with honesty and care. Plan ahead for big decisions, especially if you need a medical directive or something like a DNR, a do not resuscitate. Know those end of life care decisions for your loved one if it ever happens. And last but not least, act. Seek legal counsel if you need to. Always prioritize the health and safety of you and your loved one. Share your stories long and wide if you're comfortable doing so, and get involved at the level that you think is comfortable for you, whether it's the society level, hammering on the doors of Congress, or at the individual level, just making sure your loved one has enough to eat. Whatever level is the right level for you, get involved. And with that, I'll wrap it up because I know we were running a bit behind. I just wanted to share, if you have questions or would like more information, please don't hesitate to contact us. You can email us at solvecfs@solvecfs.org. And there's our website information there as well. So thank you again for this opportunity. I hope this was helpful, and look forward to answering everyone's questions.
Great stuff. Thank you so much, Emily. That was so inspirational and informative. I'm going to hand over to Taryn now. There we have 10 minutes, actually just less than 10 minutes to take questions. So over to you, Taryn.
Sure, thank you so much. We did have, I know Leona had mentioned, and I think Emily, maybe you didn't get time to talk about it, but something about long COVID, hearing about kind of what you were describing, sounding a little bit like long COVID. And then she also asked what we've heard about COVID vaccine side effects for people with ME/CFS. And Orla replied to her about, oh, there we go. There's Emily's link. Orla had said something about courts writing the poll on the COVID-19 vaccine. So that might be something to Google. I was just trying to Google it real quick. I'm not sure if I saw the right thing. So I don't know, Orla, if you're able to Google it and find it and link it in the chat.
Yeah, I'll try to do that.
Yeah, if you can. But if not, if someone wants, apparently there's already been a study or at least a poll on it.
Yeah.
on the side effects. So you may want to find that. Sarah's asking any predictions on when scientists might have insights into the disease, not directed to a specific panelist. Yeah, I know Terry's shaking her head. Terry, did you want to address that?
I mean, probably Wilhelmina it might be better at this than me. I think it's, probably all of us that are living with this disease know the frustration of everything moving slow and it not being an emergency or urgent, which then reflects back into, are we valued as human beings and that we have a right to be valued as human beings? There's kind of some thing to think about, with COVID-19 and folks who are COVID-19 long haulers, we may have this opportunity to learn because we can pinpoint when a person got sick. We know which virus it was. So there is some opportunities there through long COVID. And I think people are coming into the field that haven't been before. I know a lot of HIV researchers that are now interested. So I think we have this window of opportunity. And while I think we need to make sure that ME is included into all research that's about long COVID, we still need to have ME research stand on its own. And I just don't want that to be so immersed that we again get lost or silenced. I hope that there will be research in basic science because we still don't really know what causes our disease. Not all of us got the disease because of a viral trigger. So what is that mechanism that makes this happen? So my dream is for in the next 3 to 5 years, could we just find out what is this mechanism? And then once we have a target, can we get some FDA approved drugs to target, what is this mechanism? I don't know if anything's going to happen if we can't get rid of the stigma. And that is so critical to any movement in science, is that folks have to value us. And like Wilhelmina say, we have a right to be believed.
Yeah, absolutely. Wilhelmina, did you want to add anything to that?
I just will add what I usually say is that we can't guarantee that when the work will give us changes, but what we need to do, all of us, is to work to make sure that the work is actually being done. We will never get answers if they're not doing the research. I always say what we need is an army of researchers because we don't know where the answers are going to come from. Science is tricky like that. It comes from all different directions. You can't predict ahead of time. So what we need to do is to all push together to get an army of researchers interested, bringing their best thoughts, their best ideas, and working together to try to solve this illness. That's something we've never had. We've had a few researchers here, a few researchers there. We need an army.
If I may, I'd be happy to jump in on the question on vaccines.
Yes, I was just going to say, I know Orla has added some links to the chat, everybody, if you're interested on those vaccines. And then you, Emily, who wanted to talk about that some more.
Absolutely, be happy to. So I will say anecdotally from many of the patients, both with long COVID and with ME/CFS that I've spoken to and worked with, I get 100 different people and 100 different answers about how the vaccine affected them. There are reports of it improving temporarily some symptoms related to long COVID, and some ME/CFS patients also report the vaccines improving their condition. And there are some folks that also report it worsening and making their and causing a crash and making their systems much worse. So I share this because I think what it really comes down to is your individual risk and if the vaccine is right for you. I also shared that just today the FDA did announce that they are doing booster shots for people who are immunocompromised. So if you do, so many people with ME/CFS are considered immunocompromised. Like my mother is also qualifies as immunocompromised, and she did choose to get the vaccine, but we had a long conversation with her doctor about her previous reactions to other vaccines, whether or not this vaccine contains some of the same elements as those previous vaccines that she had reactions to. And ultimately, we did choose to get vaccinated after carefully considering all of those options for her personal health case. So I think the end takeaway is kind of a risk versus reward decision. If you're one of those folks who's safe at home, you don't have much exposure, and you can keep yourself safe, and then you're very concerned and you've had previous vaccine reactions, talk with your doctor about maybe if you can pass just for your own health needs. However, if you are needing to go out in public, if your job requires you to speak with other humans and be in close contact, and you have a vaccine history that is relatively untouched, then obviously the risk of death would mitigate the risk of vaccine. So again, it's very personal for you as well. But I will say, and thank you, Cynthia, for the question, I encourage all healthy caregivers to get vaccinated, because you are the first line of defense for your loved one. And if you bring that virus home with you, even if you are vaccinated, you can potentially spread it. You still need to remember that you are protecting your loved one, and you're their bridge. And if you're their bridge, things travel both ways, and you don't want to bring anything back with you that's potentially harmful to your loved one.
Can I just mention, so what we're talking about in terms of the announcement in the United States about an additional vaccine being given for people who are immunocompromised, it's not a booster. Like, our bodies can't produce the level of coverage that it needs. So it's not a booster. We're never at the level. And so, I'm a person with common variable immune deficiency. So I'm going to be a person who wants to get that third shot. So I just wanted to clarify language, that it's not a booster. We never had the coverage to begin with. So our bodies just doesn't react the way it should. So right now, I have 2 shots, but we're not real sure, like, am I protected? So a booster is going to be really for folks who got the 2 shots, don't have a immune deficiency, and that is going to boost them. And so it's a little different in terms of what it's going to do to our bodies for those folks. And, I had a long conversation with my doctor, who's my ME specialist, because there are people who have ME that don't do well with the flu vaccine. And the flu vaccine and the COVID vaccine, of course, are 2 very different things. But one of the things that she said to me was, you have ME, you have a buffet of other comorbidities, but the one that concerns me the most is that you are immunocompromised. And I am terrified of what would happen if you got this. You could end up in ICU and die. So, to the points that are being made, have these conversations with your healthcare provider. The Delta variant is very infectious, and it's really, we're seeing some breakthrough in people who are already vaccinated. And, it's a different conversation now than maybe we were having when the vaccines first came out, when we didn't think we were dealing with something called the Delta variant.
Thanks, Doug. I think we're out of time now, guys. So I want to give a big thanks to our speakers very much for all your amazing experience and knowledge that you share there today. And thank Taryn for setting up the panel and doing an amazing job of that, as always. Just to remind you or share with you there before we finish, where HHP came from was through an illness that I went through myself. And out of that, as was echoed very much from the speakers today, my insight was that what's needed is peer-to-peer information, education, and support, which are the pillars of HHP's mission. So thanks everybody so much, all of our amazing speakers, and also for the audience that's attended today. I hope that you found it helpful, and the video of this panel will be available on the HHP website, and you can also as well embed it or whatever in other locations if you'd like to share it with more people. So thank you all so much. Thanks again, Taryn, for an amazing organization and putting it all together. And we'll say goodbye now. Thank you so much, everybody. Take care.
Thank you.
Thanks a million.
Thank you so
you.
much.
Bye.
Have a great
Bye.
weekend, everyone.
Bye-bye.
Bye-bye.